Hello everyone, this is Dr. Garima Sachdeva, one of the mentors of Study MRCOG, and today we'll be discussing another talk recently released in 2022, and the topic of the talk is Impact of the Intrauterine Environment on Future Reproductive and Metabolic Health. So, if there is suboptimal early life intrauterine environment, it has adverse effects on both metabolic and reproductive outcomes. So, what could be the various altered environment? If there is altered tissue organ structure, or if there is epigenetic changes, or if there is maternal obesity, or gestational diabetes, or advancing maternal age, smoking, chronic hypoxia, accelerated cellular senescence, HPA axis dysregulation. So all these in later life, they might cause obesity, diabetes, cardiovascular changes, dyslipidemia, PCOS, decreased ovarian reserve, and affecting pubertal timing. So thus causing adverse reproductive and metabolic outcomes in the later lives. In UK, all these complications are increasing. It has been seen that 50% of the women of reproductive age are overweight or obese. 1 in 5 women are obese during pregnancy. 1 in 20 women develop gestational diabetes mellitus. 1 in 10 are smoker during pregnancy, making potentially suboptimal intrauterine environments which are seen during pregnancy. Mechanism of developmental programming. So, first starting with epigenetics. Epigenetics, what happens? It is a process of varying gene expression through changing parameters other than the genetic code. So the code is the same, however, there is altered in the expression while it occurs due to other changes like there is methylation or acetylation. These changes occur in the code which results in altered genetic expression and hence altered phenotype. So during fetal life, when the cells are rapidly dividing, while also changing in morphology and function, epigenetic reprogramming, it can cause profound effect on development of anatomical and physiological systems. Then altered tissue and organ structures. So what happens if the fetus is growth restricted? So the process of organogenesis, during the process of organogenesis, the vital organs in order to sustain the vital organs like brain, other non-vital organs like liver, pancreas, adipose tissues, muscles are compromised, and this particularly happens due to increased catecholamines and reduced oxidative glucose metabolism. So this what happens when the fetal growth restriction is there. So in order to maintain the brain development, other non-vital organs are compromised, and this later on affects the development of the baby. Then cellular aging. What is the role of telomeres? So what are telomeres basically? These are repetitive, non-coding DNA sequences that cap end of each chromosome and are important in protecting the chromosomes from DNA damage. So what happens if there is shortening of these telomeres? The cellular aging occurs, and this is particularly seen, that is accelerated telomere shortening occurs in children who are delivered prematurely and in whom the placenta are following prenatal exposure in GDM. If there are patients with GDM in which the placenta is exposed to high glucose level, it has been seen that there is accelerated telomere shortening and hence cellular aging. Then programming of HPA axis. So this modulation of HPA axis, which is integrative for metabolic and reproductive health, is also affected by maternal obesity particularly, which has been seen to alter the salivary cortisol levels. Then placenta. So changes in the placenta have been seen if there is maternal obesity, high fat maternal diet, chronic hypoxia, which result in alteration of placental morphology, particularly in the junctional zone. So placental nutrient transfer and gas exchange may be influenced in these patients. Particularly, these changes are particularly seen if mother is obese. Then these are the various maternal factors and how they affect the offspring and how can we manage them. So if there is low weight or the female is underweight, then in the offspring there can be in later life obesity and hypertension. How can you correct it? By obviously by correcting the nutrient deficiency, advising for healthy weight, and you explore for the reasons of being underweight like mental health issues. If maternal obesity is there, then it can result in fetal obesity in later life, dyslipidemia, serious disease, type 2 diabetes mellitus. And how do you manage it? By advising them for weight loss and dietary optimization, encouraging physical activity, and giving aspirin during pregnancy. Then maternal smoking also results in future obesity, hypertension, and insulin resistance in the baby. You ask them to stop smoking, and you can add aspirin during pregnancy. If there is chronic fetal hypoxia, it results in obesity and cardiovascular disease in the baby. So, how do you manage it? By close monitoring of the pregnancy, including uterine artery Doppler, and optimizing the timing of the delivery. In case mother has gestational diabetes mellitus, then there is risk of obesity, impaired glucose tolerance, and type 2 diabetes mellitus. And how do you manage it? By controlling diabetes. And then, what are the metabolic effects? So, there is a risk of future obesity, as I've told. There are various maternal factors which contribute to future obesity, and this has been explained by the HAPO study, which was a cohort study which showed increased risk of adiposity in the children who are born with mothers who had GDM, even when the maternal BMI was corrected. And as I've already told, maternal smoking also has an important influence on the long-term obesity risk, and it is dose dependent, which is associated with smoking 15 cigarettes daily. And with complete cessation, you can manage it. Then there is a concept called catch-up growth. So what happens in these females in these babies which are growth restricted in the utero? So what happens? There is in order to make them adapt to this to the limited resources, the growth hormone levels increases in them. So later in the life, they have what happens? There is excessive, there is catch-up growth in the early postnatal period because of the increase in the growth hormones, and it is commonly explained by the nutrient or oxygen restriction during the intrauterine growth. This is a useful adaptation if the postnatal environment is also likely to be resource poor and may confer a survival advantage. So these babies which are restricted during the intrauterine life, in the postpartum period, when they receive adequate resources, they tend to be obese, and this is known as catch-up growth because they have higher growth hormone levels, which was increased in the intrauterine life to compensate for the scarcity. And then ovarian reserve. So now we are discussing about how the developmental programming affect the reproductive capacity. So it has been seen that if there is suboptimal intrauterine environment, because of increased oxidative stress, reduction in ovarian telomere length, and reduction in ovarian reserve has been noted. So these patients have reduced ovarian reserve. Then second is oviductal programming. Also, the oviductal, that is fallopian tube, is related to infertility 30% of the cases, and it has been seen if there is in the intrauterine life, if there was chronic gestational hypoxia, it adversely influenced the oviductal development, resulting in tissue aging and high levels of oxidative stress. So then the third one is PCOS. It has also been seen that if there is exposure to an altered steroid milieu, it results in development of PCOS and anovulatory infertility in later life. So this is how the intrauterine environment, it affects the metabolic outcomes in the growing offspring and also the reproductive outcome. Metabolic outcome is by increasing obesity, increasing risk of cardiovascular disease, diabetes mellitus, insulin resistance, and reproductive capacity is affected in terms of ovarian reserve, tubal factor infertility, and PCOS. So this was all for today. Thank you so much.